What if your sleepless nights are more than just bad habits? What if they're your body's way of asking for restoration? I'm Adrienne Irizarry, and in this episode of Reproductive Rebel, I'm joined by sleep medicine expert Dr. Barry Krakow. Together, we'll uncover the deep connection between sleep, your hormones, your mental health, and your body's ability to heal. If you're ready to move from insomnia to integration and finally reclaim the rest that your body craves, this episode is for you. Hi, I'm Adrienne Irizarry. I'm an East Asian medicine practitioner who is passionate about women's health and helping women to live their best lives. My goal is to put you in the driver's seat of your health, offering holistic solutions for a symptom-free life. Statements made in this program are for educational purposes only and not intended as a substitution for medical consultation or advice. We do not claim to diagnose, treat, or cure any diseases. This podcast is inclusive and welcomes all gender identities. The focus of the program is on biological function, and we will use the term women throughout, but it is referencing physiological and social challenges for biology, not identity. Come as you are, I am happy you're here and welcome all performances of identity. I hope you find something helpful in this show. Welcome back to another episode of the Reproductive Rebel podcast. I am joined today by Dr. Barry Krakow. Welcome to the show.
Good to be here. Thanks so much for having me.
So I had an awesome conversation before we started recording with Dr. Krakow, and I am really excited to dive into his area of expertise, which is sleep medicine. And that is an area that isn't as widely understood. So if you could share your incredible background and what sleep medicine is.
Sure thing. Again, thank you very much for having me on the program. Sleep is a very important health issue that goes widely ignored, widely under-recognized. I fell into the field, so to speak, in 1988 doing research on people with chronic nightmares. Ended up publishing a major paper in JAMA in 2001 where we had treated women sexual assault survivors with chronic nightmares and PTSD, and we had used this non-pharmacological treatment, non-drug treatment called imagery rehearsal therapy. So I went down a very psychological pathway, even though I am an internist, not a psychiatrist. I went down that pathway trying to help people with their sleep problems. Little did I realize that in doing that, I found my niche and I became a board-certified sleep doctor. And then in learning all this information about sleep medicine, I was stunned when I found out that most of these PTSD patients in general who complain of sleep problems are suffering physiological problems in their sleep. And by physiological, I mean that something is actually damaging the brain, because that's what sleep is. Sleep is your brain waves trying to go to sleep. And if you don't let them go to sleep and you're just awake all the time or awake off and on, that actually leads to brain damage. And we'll get into that, but it's a startling discovery, although many people in sleep medicine understand it. But in the mental health field in particular, where I specialized, it's very much ignored. It's more about get some psychotherapy, take these pills. Oh, and if those pills don't work, try these pills. And if those are working a little bit, well, then let's try more dosages of those pills. Very few people get sent to a sleep medicine specialist to get a thorough evaluation.
Oh, I think that is so important to note. I have seen this in my practice and experience with family close to me who have mental health challenges that it becomes a polypharmacy experience, and they will work with dosages of different medications, which can have some really awful side effects. And
not to mention making their sleep worse.
Yes, absolutely. And it just compounds on itself rather than looking at the sleep as the core issue itself. One thing that you said to me in our screening call was that 80 to 90% of mental health issues have a sleep disorder. That stuck out to me and is totally staggering.
It is. And yet the mental health community understands that in a certain way, but they still persist in wanting to call it the secondary issue. Well, you have insomnia because you're depressed. You have nightmares because you have PTSD. That's the standard thinking for decades. And most mental health professionals, whether it's therapists, psychiatrists, psychologists, you name it, they think that way instead of saying, wait, your nightmares, your insomnia, your sleep apnea, those are all separate disorders. Why are we thinking that our mental health therapies are going to help that when they can occasionally help some people with insomnia? They can help some people with nightmares. But in general, the treatments espoused by the field of sleep medicine for nightmares and insomnia and sleep apnea, obviously, are much more superior than anything the mental health community can offer. I would like to see the mental health community adopt and embrace aspects of sleep medicine and integrate it into their own systems because it should be a regular part of their care.
Absolutely. To me, and maybe this is me being novice, and this is where I defer to your expertise, but I feel like sleep challenges would be far more simple to correct or less invasive to correct with fewer side effects. Am I crazy for saying that?
That's a great perspective, and in part, it's spot on, but there's a caveat. And the caveat is one that is very painful to have to discuss. And we learned about this all the way back in the 1980s, first doing this research on chronic nightmare patients. If you have been told over and over again that your sleep problems are directly related to your mental health problem, and now somebody comes along and says, well, wait a second, I'd like you to think another theory here. You would think that people would go, well, gee, that's kind of interesting because I've always wondered about that. I always thought if I slept better, maybe my depression would get better. I said, yeah, you're absolutely right. How many doctors have you told that to, or therapists, and they go, no, you just got to treat your depression. Even though that part is simple, there's a lot of people, it's not the largest cohort, but it's not a small proportion of people. They have been inundated with this belief for so long that it's all about the mental health that when you try to come and help them about the sleep, you have to do it very gingerly because they just have too much invested in, well, what about my PTSD? What about my depression? I have to say, well, you're working with a therapist, you've got your medication, please do that. Let's now move over here and let's work on your sleep. Well, but I was told that for them, it is very challenging. And one of the most challenging things is when we discovered that most PTSD patients that were coming to our centers for research or clinical care had sleep apnea, they were like, what? What do you mean I have sleep apnea? I've had PTSD for many years. I've been to this many therapists, this many doctors. Nobody ever asked me about sleep apnea. Why do you think I have sleep apnea? And so there's people who actually said, well, you're crazy, and left. There's people who said, no, I'm not going to get a sleep study. Every person who got a sleep study was shocked, except for those who had been already reading about our work and other people's work and saying, gosh, this is a whole other dimension to the reality of how sleep works. It isn't just psychological. It's brain waves. It's physiological brain waves. And as long as that interests you, then yes, it becomes very simple. Not that it's always easy to get somebody to use a CPAP machine. But we'll talk about that because this book, which came out about a year or so ago, I go very much in depth about how we stopped using CPAP 20 years ago. And we told people to use these more advanced devices that are much easier to use if you want to try a PAP machine.
Wow, that's amazing that there was that commonality all the way through. Now, this is a little bit of a chicken and egg situation, right? Like you have somebody who experiences a traumatic experience. This is out of scope, but I find this fascinating that they're more susceptible to having that kind of a response to a traumatic experience due to the fact that they experience sleep apnea.
You're obviously a born researcher.
I am.
So this question has been out there for decades and nobody knows what to make of it. Like we did this one study in Los Alamos. They had a big fire there and we were working with a bunch of individuals who 8 months later were still reporting sleep problems, post-traumatic stress, and so forth. And we tried to analyze it because we had done some portable sleep testing on them and found this very high rate of sleep apnea as one example. But just globally, there were people who told us they clearly had no sleep problems before that fire. But there was many more people who told us, oh no, I've been struggling with my sleep for a long time, and the fire just made it worse. So it's extremely common, and therefore that means you can't say which did come first. There's a theory some people have been working on again for decades, like, does PTSD make you not breathe well? And you go, okay, well, how could it do that? Well, it could do that by making your brain so fragmented by what we call arousal activity in the brain, which leads to the thing called sleep fragmentation, meaning you're not getting deep restorative sleep. There is some research that shows that you don't breathe as well when you have that state of sleep. So could you argue that if you had PTSD and it was giving you all these arousals in the first place, that made your breathing worse? Or is it more likely that there was something about your anatomy, maybe your throat, your nose, your neck, something that made you at risk for having a sleep breathing issue, and now this trauma just tipped the scales and made it worse? And by the way, just to put it out there, so many people think that sleep apnea is related to weight, and it often is not. Half the people who have sleep apnea are not overweight. They're normal weight or underweight.
I'm glad you mentioned that, because that was going to be a question that I posed, because there is a big misconception that sleep apnea is related to weight. And I think this kind of dovetails into another question that I wanted to ask, particularly for women, because I see a lot of women in my practice that are coming into their perimenopausal years, and their number one complaint outside of the fact that they can't feasibly take off enough clothes in public because they're too warm is that they have sleep disturbances.
Absolutely. And I was fortunate to train in 1993 with Dr. Christian Guilleminault, who's one of the leading researchers in the world. He's so prolific that he passed in 2019, but he's still publishing. And so people have all of these research projects with his name on it. I just saw one I know from 2024. I haven't checked yet for 2025, but he's still publishing. He discovered, and he was a pioneer in research in women and sleep, because he was the one who discovered that the field has been making this huge error in the way it understood sleep apnea in women. There's certain kinds of breathing events. In fact, in the book, I have some pictures of the different breathing events, and everybody's heard of an apnea, which obviously means you stop breathing, so maybe your airway's shut. But you could also have a kind of collapsibility of your airway where it's still 50% open. Well, those two events, apnea and hypopnea, they're called, people continue to look at that to this day in error, because those are not the only two events. There's a third breathing event. I've gotten so sick of this that I call it the third breathing event. Its real name is been all over the place. The medical community comes up with all these different names for that third breathing event, and they have fights about it. And you have doctors say, well, it doesn't exist. And then other doctors say, well, no, it does exist. And it's just a crazy aspect of what's going on in the field of sleep medicine that to this day has not been resolved. And I and many other individuals, both doctors and patients, have been frustrated about this. This third breathing event is very simple. Instead of losing 100% or 50% of your airflow, you're losing 10% or 20% or maybe 30%. So I always say to people, if you don't think that's a big deal, why don't you put your hands around your throat and then choke yourself about 20 or 30% and see what you think. Would you like to sleep like that? And so Dr. Guilleminault figured this out back in the 1990s, the mid-1990s, published these amazing papers on perimenopausal and postmenopausal women. He found an enormous rate of this third breathing event. He gave it the name upper airway resistance syndrome. And in fact, people who Google UARS, U, capital U, capital A, capital R, capital S, UARS, will find tons of information about it all over the internet, but not in most sleep doctors' offices. And so there's lots of women who report the problem of insomnia, whether it's I can't fall asleep. The more common one is I can fall asleep, but I can't stay asleep. And then they wake up at night to use the bathroom, and they have some problems with borderline hypertension and a variety of other symptoms. And a lot of that, Dr. Guilleminault showed in the 1990s, could be related to upper airway resistance syndrome. And because I was so fortunate to train with him, I kept my eye on the ball for that ever since. And in all of my work with PTSD patients, depressed patients, and so forth, it never occurred to me to say, oh, well, you don't have sleep apnea. Your apnea-hypopnea index is too low. That's just nothing. I say, well, no, let's look and see whether these third breathing events are showing up. And, 80, 90% of the time they did. And we go, well, no, this is a big deal. This is a very big deal. These women are suffering horribly. And many of the people, by the way, who I've met over my career have been not to one, but to two, maybe even three sleep centers. They've had sleep studies. They've been told, well, I don't see anything. You have mild sleep apnea. Don't sleep on your back. And then we'd see them at our center, and we would look for this third breathing event. And then we would get them on a PAP machine, one of these more advanced PAP machines. And they'd be very pleased and very delighted that this made so much sense to them, but they just couldn't get it communicated to the other doctors for some reason.
Wow, that's huge. As somebody who is early perimenopause myself, I think I am starting to experience what you're describing because I've never, ever had a history with snoring. And all of a sudden, I will catch myself and I'll wake up because I'll have this like a click in my throat when that happens. I have a lot of my clients that describe that too. I had one of them that jokingly said, am I just getting old? And because everything's starting to sag, my throat's closing as well. And I honestly didn't know what to say to her. So this is really fascinating. And I think that if a lot of women who are listening, because a lot of listeners of this program are right in this age and stage of their life, if they really thought about it, they probably do notice things like that they never connected the dots before.
Right. And here's a historical fact that will sound very interesting regarding progesterone. So whether or not this is proven exactly is unclear because lots of research in this area is not done. But the working theory has always been if you have less progesterone, you end up with less firmness or muscular activity of your airway dilator muscles that keep your airway from collapsing. So back in the 1960s, people were treated with sleep apnea with progesterone pills. And in the 1970s and in the 1980s. So I'm old enough that I experienced that in my first entry into sleep medicine in the 1980s. And I learned people were doing that. I also learned during a very critical time, they published a couple of papers that showed that hormone replacement therapy actually reduced sleep apnea. But that research, I don't want to say it was suppressed, but it got pushed aside because it came out around the same time people were talking about, but doesn't HRT cause cancer? Doesn't HRT have something to do with heart disease? I mean, all these things. So that's still a new area to investigate. And certainly, hopefully, that will happen. But there is that working theory that this change in progesterone is what ends up, on the one hand, being deficient in the perimenopausal woman, but now in the pregnant woman, it's thought possibly the increased progesterone is protecting the airway because the women who get sleep apnea in pregnancy are much more likely to get it in the third trimester. And by the way, I just want to make sure we get this in, that there's huge research. The man who invented CPAP, Dr. Colin Sullivan in Australia, has now published, I believe, 3 papers or more showing that undiagnosed sleep apnea is likely one of the greatest, maybe the biggest contributors to the reproductive problem of preeclampsia. And they've actually shown where you put somebody who's been hospitalized for preeclampsia, you put them on a CPAP machine, and they leave the hospital within 20 or 48 hours. Now, I don't know a whole lot about preeclampsia care, but the notion that you can do that and get this change, because preeclampsia involves an elevation of blood pressure and other concerning risks.
Wow, that's fascinating. And of course, my research mind goes, they've also released some information around the sperm contributing to the higher risk of preeclampsia. So I would be really curious to see if in preeclampsia clients, if the partner had sleep apnea and that affected his gamete production, which then contributed to this issue as well.
You mean the sperm count is supposed to actually be helpful to the
sperm quality? Yeah. If it is of compromised quality in some way, it can actually increase the chances for preeclampsia and for miscarriage, actually. Yeah. So I would be kind of fascinated now that you're saying that, like my brain's kind of running because I find this fascinating. You feel the symptoms before you understand them. The restless nights, the hormonal shifts, the sense that something deeper is moving beneath the surface. These aren't random. They're messages, invitations into the next chapter of your life. This January, step into Rebel Remembered, a year-long journey where your symptoms become signals, your cycles become teachers, and every stage of life becomes a rite of passage. Each month, we explore a new archetype, a new layer of feminine wisdom, and a new way your body has been asking you to listen. Through ritual, sound, body literacy, and ancestral remembrance, you'll reconnect to the woman you're becoming, not the one you were told to be. If you are tired of pushing through, if you are craving clarity, connection, and a map for what your body is experiencing, if you are ready for a year of reclamation, then join us for Rebel Remembered. Enrollment is open now. Your body has been waiting for you to remember.
Well, sleep apnea is linked with lower libido, possibly lower testosterone. Yep. And so there's obviously some potential there.
Wow, that's fascinating. So let's talk about this third sleep event, okay, and this disordered breathing experience. What do you do for somebody? Like, do you go the lengths that you do with somebody that has more severe sleep apnea? Or is there like a lesser intervention, for lack of a better phrase, since their symptoms are like 10 to 20% compromised rather than more severe numbers like you might find in other people?
Right. The nature of the breathing event is a problem because the quality of how we measure breathing and what it does is just not very good. People will look back on it and say, this is kind of primitive. It got the point across that there's a disorder. But no, we're not really measuring things in some accurate way that says, here's exactly what's going to happen to you. What I like to do for any individual who's interested in this is walk them through just a couple of things so that they have the ability to think, oh, this sounds really relevant to me or not. And the biggest one usually turns out to be, the two biggest ones turn out to be, does the individual realize there's something wrong with their sleep? That might sound like a funny question because some people could say, oh yeah, like I didn't sleep well last night or I wake up a lot. But I'm saying, no, I'm asking, is there something wrong with your sleep? Is your sleep broken? Is your sleep messed up? A lot of people go, how would I know? I mean, well, did you ever remember sleeping really well and now you're not? And they go, oh, sure. Okay, I can answer that question. Yes, my sleep is probably broken because I don't usually wake up rested. I said, bingo. So now do you understand what you just described is a sleep quality problem? And that means unequivocally, in like 99.9% of the cases, there's something going on physical with your sleep. That's not a psychological thing. Now, I'm not saying people can't have psychological issues and they promote bad sleep. I'm not saying that. But in general, if somebody is saying, no, my sleep is non-restorative night after night, I'm tired or I'm sleepy, I really don't have the energy I used to have, that's a sleep quality problem. And you say, well, then don't you want to know what's going on in your brain while you're sleeping? You need a sleep study. So once you get to that point, a person might be very, very motivated. But another way to motivate is if there's a behavioral symptom that really aggravates their sleep. And the most common one, and it really is a great selling point, if I can use that phrase from the point of view of trying to help patients and clients learn about this. People think that trips to the bathroom at night is normal. They think that you're supposed to go to the bathroom once or twice a night. They hear it from every single doctor they go to. It turns out that sleep breathing disorders, even a breathing disorder of the third event, UARS, and only UARS, no apneas, no hypopneas, just the third breathing event, not only can cause high blood pressure, but it can cause you to wake up at night once, twice, 3, 4, 5 times a night to urinate. And the reason it does it is a little bit complex. I have a video. It's a free video. It's 5 minutes. It's on my website, barrykrakowmd.com. The video is called nocturiacures.com. Nocturia is when you try to breathe and you can't, you're putting a tremendous strain on your heart and on your lungs, and they don't like it. And there's a whole chain of events that occurs inside your body where your blood supply circulation is altered by all this resistance and pressure building up. And your heart goes crazy thinking, what is going on with my heart? Why am I getting all this extra fluid into my heart? And the next thing you know, the heart releases its own diuretic. The body has its own diuretic for just such circumstances. Your body, by the way, is not fluid overloaded. This is not congestive heart failure. This is just a little bit extra fluid going into the right atrium of the heart. And the heart says, no, that's not right. Sends out the diuretic, the kidneys go into action, and you wake up 1, 2, 3, 5 times a night. People treated for sleep apnea, people treated for UARS will see a marked reduction in trips to the bathroom. In some people, it can be down to 0. It's very common for it to be down to 0. A lot of sleep doctors don't even know that because they're not looking at the third breathing event. Mm-hmm. They thought they'd finish their work by treating the apneas and the hypopneas, maybe. I'm not sure, really. But the more aggressive you are in treating all 3 breathing events, you actually see more decline in the number of trips to the bathroom. So those are the 2 big selling points. One is sleep quality, and then one is nocturia. And these are the ways the person gets really interested. But then the next part is where we've developed this over the last several years, and this is in this book. I've got another book out too recently called Fast Asleep. And this one is a little bit more of the behavioral steps that are needed, can help anybody even with sleep apnea, but also more designed for insomnia. This one has a whole conservative treatment steps. In other words, I don't want you to hear all of this and say, oh no, sleep studies, sleep labs, CPAP, because it turns out now that we really understand this process, a lot of people shouldn't start CPAP right away. And the reason is it's just too difficult. But now you got to hear the reason why it's too difficult. Their nasal breathing is not good. And they really need to work on their nasal breathing. They may have sinus problems. They can have allergies. They can have a condition we call non-allergic rhinitis. And so we built this whole conservative treatment program in the book that talks about you can learn to use nasal sprays to clean out your nose. You can use nasal strips, nasal dilators. You can change the position you sleep in. You can change the temperature because cooler temperature, you actually breathe better. So what if you do all those conservative steps? Because they're easy, right? What if you do them and like 3 months later, you're going, I am sleeping better. I guess I do have a sleep breathing disorder. Well, you know what? Penny in for a pound. I want to get the real deal here. If I can get more benefit by trying a PAP machine or a dental device or a surgery, why not? But see, look what happened. That person started out and learned about the quality of their sleep. They learned that they might be waking up to pee for this particular reason, and they really want to solve that. And then they're given these steps to learn and observe their own sleep health. Now, sure, there's some people, the condition is so bad, they would do very well to go to the sleep center right away and get a PAP machine. You know, do not pass go, do not collect $200. You just get started, you're really going to feel better. But there's a whole bunch of people who hear this that are not ready to jump in the deep end of the pool. They really need to try these conservative steps. And we have been so pleased by the number of people who come back to us and say, gosh, this is so cool. I'm sleeping better just with nasal strips.
That's awesome. So the book that Dr. Krakow has referenced is Life-Saving Sleep. We will have a link for it in the show notes. both of his books will have links in the show notes so that you can check out these really great resources. But I think this is really important for people to know that there are things that they can try to do to be able to create a more empowered sleeping experience. And I bet that there were a few people that when you were talking about multiple trips to the bathroom at night, they were like, oh, I feel so seen right now. Do you find that that happens more in certain age groups, or do you find that that can just kind of happen across the board if people are having sleep difficulties?
Do you mean the trips to the bathroom? We're talking about that specifically?
Yeah.
Shockingly, you can have the trips to the bathroom as early as being a teenager, being in your 20s. People, by the way, who unfortunately go misdiagnosed, they're told, oh, well, I'm sorry, your child has enuresis. Some of that is related to undiagnosed sleep apnea, large tonsils, adenoids, difficulty nasal breathing in the child. And they never figured out until the kid's a teenager or a young adult or never. And they say, oh, yeah, I was a bedwetter. Oh, well, did they ever evaluate your sleep? No, never. All of these things, the sleep has so much to offer so many people in so many different realms of health. But going back to one of our main points of topic, that is very disturbing how many women I have met who are, if I don't know if it's the right word, disenfranchised from the sleep world because people say to them, well, we didn't find much here. So go back to your psychiatrist and get some more pills. I've heard that particular line, I'm going to guess 400 or 500 times in the last 20 years.
I'm sure. In general, a lot of women's health-related symptoms have responses like that. Either go back and get more medication, or you're just too emotional, and they get gaslit in that whole, like, I'm having symptoms kind of experience. I mean, I've had some of my clients that think sleep apnea is only a male problem. Oh, my husband's a little overweight and he like clicks and stops breathing in his sleep, and they don't even think that it can happen to them as well.
All right. So let's get down to the nitty gritty in terms of emotion. So let's do the thought experiment of you're going to stay up all night, every night for 3 nights in a row, and you're going to sleep a couple hours during the day. On the 4th day, how are you going to feel? What are your emotions going to be like? Now, I say that in a little bit of a comical way, but the tragedy of it is that if you look at individuals who are at risk with suicidal ideation, suicidal behaviors, and sadly, those who've had completed suicide, there's tons of research showing that sleep issues, insomnia in particular, and probably sleep apnea, also nightmares, that these things are absolutely destroying the emotional integrity of the individual. I'm not saying they don't have other disorders. I'm not saying there aren't other reasons why somebody could be suicidal. But when you throw in, by the way, we're going to assault you every night when you try to get your rest, the respite you desperately need from reality, which is called sleep, where the brain is supposed to do its special cleansing operations during the night to heal the brain. No, you're not going to get that. We're going to awaken you all night long. We're going to give you bad dreams. We're going to make you have trouble breathing so that you feel like you're under attack. And now you're saying the next morning you're going to wake up and like that's not going to affect your mood, your emotions, your depression, your anxiety. It's ridiculous. Of course it is. And that is being overlooked. And it is most unfortunate because when you read all of these things in the media about certain cases of suicide, and you're hearing more about them, again, another spike, there's almost never a discussion in any case where somebody said, oh, and by the way, they had gone to a sleep doctor 2 weeks beforehand.
Yeah.
No, they had gone to their psychiatrist and gotten more pills. And then the dosage of the pills was increased, but never evaluated by a sleep doctor, even though the story mentioned that must have been part of what was going on. It's a big deal, and it's just not looked at. Sleep, again, has so much to offer, and many people do suffer suicidal ideation because they wake up and they are feeling primed to have a bad day.
So how does one get started, essentially? So you're going into your doctor's office, and you're being referred to a psychiatrist or a psychologist, they are using the tools that they are most familiar with in their toolkit. Is this you walk into your PCP's office and go, hey, I want a sleep study? Or how do you start advocating for yourself so that you can get the proper support if any of these themes are resonating with you?
Two steps that are fairly straightforward that usually lead to the answer to your question, which is one, self-knowledge. Do you really want to evaluate your own sleep and say, hey, wait, it sounds like I need to really study my sleep more to figure out, do I think there's a problem? And if I do I know what it is? And then if you have trouble, you can read this book because this tells you how to evaluate your sleep, but also it gives you the terminology to use when you're talking to that doctor. Once you've gotten to that place, then you walk into that office, and knowing that in most doctors' offices, if you want to get anywhere, you've got to be diplomatic. You put forward an idea and say, I know we've been prescribing the Ambien before, and I've told you sometimes it worked, sometimes it didn't. But I was reading recently about all of this, and I really wonder if I need a sleep study. That would be one very simple way to do it. Unfortunately, some of those people have already done that. Now you're talking about, but wait, what if I went to a sleep doctor and they said, well, I'm not doing a sleep study on you. You're a psychiatric. That also happens very commonly.
Yep.
So the challenge is that the individual has to be perseverant. I run on my website, barrykrakowmd.com, a sleep health coaching service. And in that, more than half the time, I'm having to help individuals who are in various phases of this where they've been on CPAP and they can't convince a doctor to get them on bilevel, or they can't even convince a doctor to do a sleep study, or they're on bilevel and the doctor isn't really sure how to use that and make everything work in a better fashion. So I educate them and give them, again, much more knowledge, and now they're much more equipped than to go and speak to other doctors. Now, where it's incredibly tricky is once you start getting into this, you would hope that individual will then go back to their psychiatrist and psychotherapist and say, look, by the way, I got this whole new program I'm doing, and I'm not asking to change my medicines or ditch them, but I hope that you will work with me, that if I do start to sleep better, that we can reevaluate some of the things in the program that we're doing. I would think most people will be very receptive to that. But the only issue is, what does a psychiatrist and what does a psychotherapist know about sleep medicine? And the answer today is not a lot. And so they might be saying something more like, well, sure, let's see what happens. When I talk to my psychotherapist friends, and I have many, I say to them, you know that if you have a patient sitting across from you, that you're struggling to get them to listen to you, that you're struggling to get them to understand your instructions. They're coming back to you and they say they couldn't really follow through on the steps you outlined. You realize you're describing somebody who is potentially cognitively impaired. And yes, depression could cause that, but so could a sleep disorder. And keep in mind that if that's the case, you're going to continue and they're going to continue to bang their head against the wall because they can't really digest the salient psychotherapy techniques you want them to learn and apply. And this is a very common thing. This is a place where psychotherapists can get very deeply involved, and the same with psychiatrists if they want to learn about sleep medicine.
And I think that's a really important piece too, because then you start internalizing that there's something wrong with you when you keep trying the same things, expecting different results, and nothing gives, right? And so for a depressed person, that's really just going to compound the negative self-talk that they give themselves, which just makes the whole problem worse. So I am so grateful that you reached out to the show and that we were able to have this conversation, because I think that this is an area that we need to have far more conversations about. People need to be aware of. I know that in the span of this conversation, I've had lots of little bells go off in my head about things that can support my family and my clients' health, and places that I'd be like, hey, maybe you should go have a sleep study. See what you can do about getting set up with one. And I know that I'm definitely going to do more advocating for that. So definitely check out Dr. Krakow's books, Life-Saving Sleep, and the other. Fast Asleep. Yes. I was trying to remember the name off the top of my head. These are really great resources. Like I said earlier in the show, the links will be in the show notes so that you can empower yourself. That's the whole purpose of Reproductive Rebel, is to shine a light on areas of practice that are bringing really great information forward that might be lesser known, so that people can make informed and empowered choices about their health. And I think this is a really important one. So thank you so much for your time and for sharing your expertise with us. I really appreciate it.
You're welcome. Can I give you one PS?
Yes, absolutely. I was going to ask you for a final thought.
Well, just because you were ending on depression, one pearl we learned many years ago, it's extremely common where people can fail the first attempt at an antidepressant. By the use of the word fail, I mean the drug didn't work for them. The patient didn't fail. I mean, some people don't use them properly, but many people can go through the experience where it doesn't work. And it's a tricky thing because sometimes they take weeks for it to work. But in our clinical work over the years, many people have noticed this, that if somebody is reporting this problem of, I tried this antidepressant and then that antidepressant, there's a lot of people who do switch around their medications for a variety of reasons. But with depression in particular, that often tends to be a sign that there's something wrong with their sleep, often tends to be sleep apnea. If these antidepressant works extremely well, that suggests something maybe is less problematic with their sleep. Obviously, all cases are individual. But we were surprised how many people would say that, oh yeah, I had tried multiple drugs before for depression, and they never could seem to get one to work that well. Or when they did, it was the fourth one. You say, okay, well, maybe, but let's test you. And that proved to be valuable. Thank you very much for having me on the program. And I think we had a great conversation.
Yes, thank you so much. All of the information to reach out to all of the great resources that Dr. Krakow offers will be in the show notes. And until next time, everybody. Thank you for joining me for another episode of Reproductive Rebel. Reproductive Rebel is recorded by certified peri-steam hydrotherapist and acutonics practitioner, herbalist, and Chinese nutritional therapist, Adrienne Irizarry of Moon Essence LLC. If you are interested in setting up an appointment for one-on-one support, ordering from our store, or checking out our course offerings, visit our website at moonessence.life. Be sure to subscribe to our newsletter and get insider information on upcoming events and offerings. Join the conversation. Like and follow us at MoonEssenceMe on Instagram, Facebook, or LinkedIn. Your voices make this program possible. Thank you all for your continued support.